I'm Dr. Fernando Pagan. I'm a movement disorder neurologist at Medstar Georgetown University Hospital. I see patients with movement disorders, which the most common movement disorder is Parkinson's disease. So Parkinson's patients who have disorders similar to Parkinson's disease, patients with tremors, abnormal muscle spasms or dystonia, patients with tics or Tourette syndrome, and patients with cerebellar problems that lead to abnormal gaits like ataxia. So these are the types of patients that we see in our movement disorder clinic here at Medstar Georgetown University Hospital. I really like my job because we really can make a difference. Neurology has really turned into a field where we can really be hands-on and intervene and modify diseases and improve quality of life. We're actually changing patients' lives now in neurology, and I really see that when I get to see a patient come in who is in a wheelchair and the next visit they're walking. That's pretty amazing. One of the reasons to come to Medstar Georgetown University Hospital, especially in the Movement Disorder Center, we are a National Parkinson's Foundation Center of Excellence. We're taking care of the whole entire person. We don't only look at the tremor, we don't only look at the stiffness of a person or the slowness that they're having from the disease. We really take a look at the whole person. We look at medication, alternative treatments. We also look at physical therapy, speech therapy. We really try to find every single type of treatment possible, even surgical intervention, to help improve the quality of life. What's unique about Medstar Georgetown University Hospital's Deep Brain Stimulation program is that the whole entire team is present in our facility to be able to help improve the quality of life. In order for DBS to be successful, you need a very skillful neurosurgeon, you need a neurologist to refer you to make sure that you do have Parkinson's disease, a neuropsychological testing as well to make sure that the cognition is intact, and then you need the follow-up to readjust the medications and adjust the deep brain stimulator. And then the ultimate piece is the physical therapy, and specifically for Parkinson's disease, as we adjust the stimulators and adjust the medication. So neurosurgery and neurology working together in the same facility, I think, enhances the quality of life of our Parkinson's patients, and that is unique to Georgetown University Hospital. Research is also an important part of our clinics here at Georgetown University Hospital. Medstar is committed to excellent care, and that really does also include research. We have a lot of clinical research programs. We're looking to see how we can enhance the quality of life of our patients, not only today but in the future. Sometimes we have certain treatments that are only available in the clinical research side and will soon be available in the clinical world. For example, over the last couple of years, we've had patients who have been getting the Nupro, or the rotidogene patch, which was only available in research clinical trials, and it will be finally available here in the United States. So our patients have already had that exposure and been able to have an improvement in quality of life before it was available clinically. One of the other things that we're looking at very intensively in research is looking at new ways to deliver medications. So we not only do we have deep brain stimulation, enhanced quality of life, but we have new drug delivery systems or pumps to deliver the medicines continuously throughout the day, and that we do and have offered that to some of our patients in clinical trials. And so we're changing the way medications are delivered, or changing the way we're going to have therapeutics for our patients in the future. Parkinson's disease is defined as a motor disease. It's based on motor symptoms that we can see in individuals. For example, slowness in movement. So they're not moving as quickly as they were before is one of the diagnostic criteria. Another diagnostic criteria is something called rigidity or stiffness of muscles. And the last one of the triad is tremor. It's usually a rest tremor. About 70% of Parkinson's patients will have rest tremor. So that means 30% will not. So the one criteria that does have to be present is that there is slowness in movement or bradykinesia. So bradykinesia, the slowness in movement, rigidity, and tremor is what we classically use to diagnose Parkinson's disease. It's a clinical diagnosis. In other words, we see the symptoms, and then how a patient will ultimately respond to the medications will ultimately tell us whether somebody has Parkinson's disease or not. One of the things that we're learning about that there's a lot of non-motor features about Parkinson's. So patients can not only have motor symptoms, they can have other problems. So constipation, for example, can precede the motor symptoms by almost a decade. REM behavioral sleep disorder or sleep problems can also precede the diagnosis by several years as well. Anxiety, depression, problems with smell identification. So we're also learning that Parkinson's disease is much more than a motor disorder. It also has a lot of non-motor issues as well. I believe that we will redefine Parkinson's probably within the next several years, because we're learning that at the time that we actually diagnose Parkinson's disease, there has been a loss of about 60 to 80% of all the neurons that produce dopamine. And that's what causes the symptoms of Parkinson's, that if you're not producing a chemical in the brain called dopamine, you start to develop slowness in your movements, the rigidity, and possibly a tremor. So by the time we've made the diagnosis, we have already seen this degeneration occur. And what we're learning is that when you've lost somewhere between 40 to 50%, that's where the non-motor symptoms are present. So over the next decade or so, we're going to have to push the envelope into making the diagnosis before the motor symptoms are there, so that we can start to intervene and potentially slow down or stop the progression. We make the diagnosis of Parkinson's based on the clinical symptoms. Usually another physician or a family member or friend have noticed that somebody is no longer moving one arm as well as the other, so the arm swing is decreased, or they've developed a rest tremor, or their handwriting has gotten a little smaller, they're waking up with a lot of early morning stiffness, they're having a stoop posture. So those are the symptoms that usually bring the patient over to a neurologist. Again, the motor symptoms are the ones that usually come to a neurologist. Sometimes the patient has been having some vague symptoms for a while. Difficulty with sleep, constipation, muscle cramping, and they may have been complaining to their primary care physician for several months or several years, and they've never really been able to figure out. But once you start to see the muscle stiffness and the tremor, that's when we usually see them in neurology. We make the diagnosis based on the clinical exam. We do a full neurological workup. A lot of times we may or may not get an MRI. The MRI usually is normal. And nowadays we can even, for some patients that were kind of on the fence, or there may be some atypical features that we may need some confirmation based on our clinical exam, we can order a scan. It's called a DATScan, which is a beta CIT scan. This is a type of like a PET imaging or positron emission tomography. It has some similarities to it, very similar to what we'll do for patients with Alzheimer's or even some of the neoplastic disorders like cancer. We can get a brain imaging to tell us about the content or how many dopaminergic neurons there are in the area of brain called the basal ganglia, which is very important in the pathophysiology of Parkinson's. So we can actually do a nuclear medicine scan to help us with the diagnosis or confirm for some patients. So we have a lot of different medications available for Parkinson's disease. The gold standard continues to be levodopa. That's a precursor for dopamine. Parkinson's disease is based on motor symptoms that are caused by deficiency in the neurotransmitter dopamine. So anything that we use to enhance dopamine can be very beneficial for Parkinson's. The gold standard, again, is a medicine that combines levodopa with a drug to prevent side effects called carbidopa. Sinemet is the trade name for that one. So that's kind of the gold standard. But what we're learning is the amount of carbidopa, levodopa, or Sinemet that you use can lead to complications later on. So using the minimal amount to give the best quality of life and potentially more continuous drug delivery of this compound rather than a very pulsatile dosing is what seems to be best for patients right now, what we're learning. When do you use levodopa is where the question really is. When you see a patient with very mild symptoms, sometimes we can get by without using levodopa first. Although it's the most potent, you can use other drugs. For example, you can use a monoamine oxidase B inhibitor. One of the most common ones that we'll use is called rasagiline or Azilect. This medication stops the breakdown of dopamine so your body can recycle or reuse the dopamine that you've made naturally, and sometimes that can help improve the quality of life rather than using no medication whatsoever. So for a very mild patient, this is a great drug to start off, very well tolerated. If a patient has a little bit more symptoms, you can use something like a dopamine agonist. The most common dopamine agonists that we have are pramipexole and ropinirole are the main ones. We even have one-a-day formulations, again, to have more drug delivery. And very soon we're going to have a patch called rotitogene, or the Nupro patch, that also will deliver the drug nice and continuously. You see this theme of having drugs are now once a day and more continuously delivered, and I think this is going to equate to better quality of life. And we're learning by giving the medications this way, not only do we help enhance some of the motor symptoms of Parkinson's, but the non-motor symptoms as well. So that's really very fascinating what we're seeing with this new type of drug delivery. And this is something that's clearly new now in this decade that wasn't available previously. As the disease progresses, then sometimes we have to be a little bit more aggressive. We'll sometimes use a combination of certain medications to enhance levodopa. For example, we can use a COMT inhibitor as well. That also helps prevent the early breakdown of levodopa, so more of it gets up into the brain. So we can use older medications like amantadine. The trade name was Symmetrol. This medicine helps release dopamine, and if a patient has developed dyskinesias or motor fluctuations, this can help with these types of symptoms as well. But once we start to get into the motor fluctuations, that's where we could potentially consider other treatments that are a little bit more invasive but could improve quality of life significantly. The main one right now that's FDA approved here in the United States right now is the Deep Brain Stimulator. I often get asked that question, is Parkinson's curable? Right now, the way that I like to look at it is we can modify the disease. We improve patients' quality of life dramatically. We can get a patient with the proper medicines in Parkinson's disease to feel like they don't have a disorder so that they can continue to live their daily life and enjoy their quality of life, be able to attend family functions. In the future, hopefully we'll find treatments that not only slow down but stop the progression of Parkinson's. And I think that's where gene therapies and stem cell research are headed. Gene therapies, I think, have the best hope to stop the progression of Parkinson's, and then stem cells could replace the loss of the dopaminergic neurons that we've had. So stem cells are a replacement, and gene therapies would stop the progression. And I think we need those two together to ultimately come up with a cure. Right now, a patient without treatments in Parkinson's clearly progresses much quicker than with a patient with treatment. So treatments do modify. In fact, if you take a look at the history of Parkinson's disease, before 1970, patients with Parkinson's disease expired or died much earlier than that of the general population. Since 1970, since we've had treatments available for Parkinson's disease, Parkinson's patients are living just as long as that of the rest of the population. But what we need to do is we need to improve their quality of life with these medications. So they're living longer, but we have to give better medicines, better drug delivery systems to improve the quality of life as well. Deep brain stimulation is a treatment that can be considered when we start to see our patients start to have the motor fluctuations or their tremors are not controlled by the medications. There's a small subset of the population that the tremor is resistant to one of our best drugs like carbidopa, levodopa. There, deep brain stimulation is better than the medication. In general, deep brain stimulation gives you the same effect that our medicines like carbidopa, levodopa give you, but for longer periods of time. So we have a patient that's starting to fluctuate. They're wearing off. They're having difficulty taking so many medications throughout the day. This is the ideal patient for deep brain stimulation. So deep brain stimulation is a pacemaker is a pacemaker device, but instead of inserted into the heart, it's inserted into the brain. We have two areas in the brain that we use for Parkinson's disease that we can put these electrodes in. One of them is called the STN, that's short for subthalamic nucleus. The other one is called the GPI, or globus pallidus interna. These are set of nuclei of the basal ganglia. When you have a dopamine deficiency, there's an overstimulation coming out of those two areas. What we do is we put in an electrode there and we overstimulate, we drown out that overstimulation coming out. We're actually mimicking the same effect that carbidopa levodopa does. When you give a Parkinson's patient this carbidopa levodopa, that overstimulation that's causing the stiffness, the rigidity, and the tremor resolves because that stimulation that is overactive, now the medicine brings it down. Now, with the deep brain stimulator, we can mimic the effect of carbidopa, levodopa, or cinnamate. I like to call it electrical cinnamate because it does the same thing as cinnamate, but just in that localized area. So you can put the electrode there into that nucleus and start stimulating there and drown it out so a patient's tremor can go away and their rigidity and stiffness can go away. They can move their fingers much quicker, they can walk faster, their arm swing returns. So the motor symptoms with deep brain stimulation are improved dramatically. And the right type of patient is a patient who is responsive to the medicine, but is having more of these motor complications or motor fluctuations. After the deep brain stimulators are inserted, we usually wait about 4 weeks before we actually turn it on. Because a lot of times there's a little swelling around the electrode, and some patients get benefit already just after placing the electrode. We can do our best program after those 4 weeks. At that 4-week mark, we turn on the stimulators for the first time and we begin to start adjusting the medications. Usually we can reduce the carbidopa levodopa about 30 to 60% depending on the patient. And then we usually see our patients about every 4 to 6 weeks for the next 3 to 4 months to really fine-tune the medications as well as the deep brain stimulators. We want to enhance the quality of life of our patients. We know it's going to take time. It doesn't happen right away. A lot of times immediately a patient feels better when we've turned it on. They no longer have tremor, but we do need to follow those patients to optimize. We want to use the minimal amount of medicine and the right amount of stimulation so that we don't cause side effects and we improve the quality of life. In general, we can improve the on time. That's the amount of medication when the medicine is working, about 4 to 6 hours in a Parkinson's patient after deep brain stimulation. The best that I could do as a movement disorder neurologist by adding another medication is about 1 to 2 hours at most. So there's a huge difference in quality of life, but it's a process. In the past, 10 years ago, we would have to put one pulse generator on each side. So now we have one that controls for both sides, and it's also gotten smaller over that time. We also have a rechargeable one that we can actually recharge through the skin, and that can last up to 10 years. As a programmer, I have seen that I have a lot more ability to give to my patients. For example, I can adjust or give certain groups to my patients depending on what they're doing. I have certain settings for my patients nowadays for when they're talking on the phone versus when they're just walking or riding their bicycle or competing. One of my, for example, I have one patient that he will use group A for his normal activities. When he goes to work, he'll use group B. If he's on the phone, he'll use group C. But when he's competing he does some competition with bike riding, he'll be on group D. He can't talk, but he can pedal like the wind. So you can really tailor the specific therapy depending on the patient. When we first started doing this, we had about 12,000 options for programming. Now we have over 22 million options to really fine-tune that programming to get the best quality of life for our Parkinson's patient. What that's meant is there's probably less repositioning of electrodes that there used to be because we can find something in between to improve the quality of life of our patients. So there have been significant advances in the pulse generation, the pulse generators, in other words, the pacemaker of the deep brain stimulator over the last several years. And I still think there will continue to be advancements over the years. When we used to give a patient access review so a patient could just tell whether they were on or off, it was just a couple of lights and a couple of beeps that they would hear. Now it's a whole entire LCD screen. They have almost like a little mini programmer like I have, and I can give them ranges so they can adjust themselves if they want to or if they need to, and they can choose it. And it actually tells you what group you're in, A, B, C, or D. Again, I have some patients who are just in group A, but I have patients that I give them 4 different groups, and I can stimulate them 4 different ways depending on what they're doing. So the future of Parkinson's, the way that I see it is we're going to see better medications, and we're going to see better ways to deliver the medication for symptomatic improvement. And then we're going to see treatments like gene therapies or stem cells to stop the replacement, to stop the progression of Parkinson's or replace the neurons that we've lost. In gene therapies, where I see some improvements coming, we've seen some gene therapy trials where you use a viral vector injected into the brain to increase GABA. Most of the time when we talk about Parkinson's, we're talking about dopamine. There's other neurotransmitters involved. They used a viral vector with something called glutamic acid decarboxylase, or GAD for short. When they put the GAD there, patients who got the real surgery versus the sham surgery, they improved in their motor symptoms. So there may be other ways to treat Parkinson's than just delivering dopamine itself. But we'll see trials within this decade, not only for GAD, but also nerve growth factors and even other enzymes to enhance dopamine production. And the hope is to be able to develop a gene to stop the deposition of an abnormal protein called alpha-synuclein that we see deposited in brains of patients with Parkinson's disease. Very similar to what we hear what's going on with Alzheimer's, but with Alzheimer's is beta amyloid. So I do see a significant future there with the gene therapies, but we need further research. The DATScan is a new nuclear imaging test that we can use to help us with the diagnosis of Parkinson's or Parkinson-related disorders. It doesn't differentiate between Parkinson's disease and Parkinson-related disorder, but it could definitely tell us that there's been a loss in the amount of dopaminergic neurons. But there's other areas that I think that DATScan can be helpful in the management of Parkinson's, and it's going to continue to evolve. We're still at the very early stages, but it can be a very useful tool for us neurologists and also for the patient to help them identify this disease. And that is also available here at Medstar Georgetown University Hospital.